Hello, good morning. My name is Mary Bennett Hinson, and I am a Nurse Corps officer in the United States Navy. Today, I'm presenting to you all on the use of the EZIO intraosseous access, and we're going to be breaking this down from the supplies that you need, the reason why you might put it in, how to put it in, and how to safely remove it. This is a skill that is really important for all medical personnel in the Navy to know how to do because we don't know when tragedy is going to strike, when a mass casualty might happen, and when we need to get access on patients very quickly to save their life. So that is kind of the heart where the reasoning behind this presentation. So let's dive in. Let's go over our learning objectives. During this presentation, you're going to be able to verbalize the reasons or the indications why a patient might need the Aero EZIO system. After that, you're going to be able to tell us the reasons or the contraindications why someone may not be an appropriate patient for the Aero EZIO system. Then once you know the indications and the contraindications, you can safely learn to gather all the appropriate supplies for this system. You're going to be able to know how to place the system via a step-by-step process, how to safely identify that the system is actually working, and then when it would be an appropriate time to remove the system and how you care for that site. So that is our learning objectives and kind of the overview of the flow of this presentation. For the Aero EZIO system, there's a few indications that would make this an appropriate thing to be placed. The easiest example is that it is an emergency. This is not something that we are going to be placing in stable patients that we do not need vascular access on. Usually we will have tried to place an IV, intravenous access, once or twice prior to placing this system. Also, the patient's vital signs are not going to be stable. For contraindications, there's three that I want you to pay attention to here. If the site that you choose has an active infection, that's obviously not going to be an appropriate place. The second is if you suspect that there's some sort of loss of bone integrity, meaning they've had a history of the IO in that same leg or arm, say within the last 48 hours, if they have some sort of abnormal pathology, or if they have a suspected fracture or a fracture of that bone. There's a few fluids that you don't want to put through an EZIO system. And those are listed there before. You don't want to put in TPN, which is total parenteral nutrition. You don't want to infuse chemotherapy drugs, and you also don't want to prolong the use of hypertonics like 3% saline or mannitol. Those can be kind of damaging to the area, so you can give those in the short term, but you don't want to in the long term. So now that you've determined that your patient needs the EZIO system, let's go over the supplies that you need. You need the actual drill itself, which is the machine. You need to pick an appropriate size needle, which we'll go over on the next slide. You need to have a pre-filled syringe of normal saline. A 10 ml works just fine. If the patient is awake or if time allows, then you want to give the patient lidocaine. The next would be you want a sterile syringe, an empty syringe, so that you can, one, check for patency, but two, you also probably are going to need to collect some blood for labs. You also need some sort of disinfectant agent to clean the site. Chlorhexidine or alcohol would work fine. You need your own personal PPE and a stabilization device so that after the device is placed, that we're not going to lose all of our hard work. As mentioned before, here is the photo of the EZIO drill. This is the brand, the Aero EZIO, which is what is standard across all military treatment facilities. You also see in this picture the 3 different needle sizes, and we're going to go over those in a little bit. You also see the connector in the middle, which is what you're going to flush with normal saline and connect that at the hub. And then the stabilization device as mentioned previously. So now that we've gone over our indications and contraindications, we've also gone over the supplies needed for this procedure. Let's go over the actual sites itself. There's going to be a photo on the next page that's going to break down these sites in a picture format, just in case you're a visual learner. But here, let's go over the sites. The blue is the adult, the red is pediatric. You can see here the proximal humerus head is the least painful site. You can also really infuse things very fast, so you can, this is good for cardiac arrest. The proximal tibia, however, is probably the most commonly used site because it is kind of considered the out-of-the-way site, and you can still give a liter an hour, which is pretty fast. This site is pretty painful though, so I would not do this on an alert patient unless I absolutely had to. And then the distal tibia is further away, but it's the least direct access site, and I don't see this used very often. For pediatrics, you can use all the sites listed above, and the distal femur head is also an authorized use for pediatrics at this time. So this slide is taken directly from the Aero EasyIO website, and I thought that it really just did a great job at breaking things down. I want you to take a look at the picture on the left side of the screen to see the sites that we discussed on the previous site. I also want you to take a look at the angle at which you are going to place these, and then the appropriate needles. So for adults, you can see there the blue needle or the yellow needle is appropriate. Generally, the blue one is the size that's most standard across the board that you're going to see most often. However, the yellow would be, if you think you have a patient, say it's an active duty Marine that has a lot of muscle mass, then you may want to consider using that yellow site. If you also have someone that is considered overweight or obese, then that yellow needle that's larger might be a more appropriate use. So use your common sense judgment there when you're picking your needle size. Also, please pay attention for the proximal and distal tibia. You want to go at a 90-degree angle. However, when you do that proximal humerus, it's easier if you are kind of going at a 45-degree angle pointing towards the hip. This slide shows us the considerations for a pediatric patient. As you can see, they have the same sites as the adult. In addition, they do have that distal femur site. They, again, break things down, the appropriate angle for insertion, and also the size of the needle. You notice here that you see all three needles listed. This is because you can use technically a larger needle on a smaller patient. The key is whenever you're placing the needle, you want to stop as soon as you feel a pressure change or almost like a pop sensation. This tells you that the needle is entering kind of that medullary space, and you can pause there, and it's okay if the needle is kind of sticking out of the skin. That's to be expected if you're using a larger needle on a smaller patient. You just want to secure that needle very well so that you don't lose your sight or so that you don't advance the needle too far. One last note on needle size selection here. So you can see it broken down on the left in the chart that I wrote. The pink size is going to be for very small children, neonates. The blue is the most standard site, so that can you're going to see that most often. And then the yellow, like I said, can be for any patient, but technically is for patients with larger kind of muscle mass or adipose tissue. Okay, at this point in time, you have verified the need that the patient actually needs an intraosseous access. You verified the right patient, that the situation warrants it, and that you have a physician order. You've prepped all of your equipment as we've discussed. You've donned your PPE, and now you have positioned your patient in the right place. You've identified the site that you want to use, and now it's time to place the line. Here it talks about the actual placement, but I want to talk about holding the leg or the arm for a moment. When I was a junior nurse corps officer, I was working with a pediatric resident who we responded to a pediatric code. It was a drowning patient, very sad case. We were in the middle of CPR. We decided that we needed to place an intraosseous line. The resident performed all the steps that you see here. They cleaned the site, and in a steady movement, they inserted the needle until it contacted the bone. However, once that loss of resistance was met, the provider, I'm assuming just out of kind of adrenaline and maybe lack of experience, unfortunately, kept drilling. And whenever he did, he consistently squeezed that trigger. It bit into the bone, it went to the marrow, and it actually came out the other side of the infant's leg. And I share this with you because it is easier than you would think. So as soon as you feel that loss of resistance, stop drilling. Another thing, if you have a spare set of hands, have someone else hold the back of the leg, the front side of the leg, and never the back side of the leg for you. You don't want to risk injuring yourself or your teammate. And I have seen that happen as well in codes. So just remember, you practice like you play. Make sure that you're holding the front side of the leg, and in a steady movement, you insert that needle until it contacts the bone, and then you squeeze the trigger just enough until you feel a loss of resistance. So we've already discussed when you stop drilling. After that, you're going to remove the drill from the needle and the catheter, and then you remove the catheter from the site just like you would an IV line. You apply that stabilization device, and then you're going to hook up your syringe. You're going to check for patency to make sure that you have a little bit of blood return, a little bit of marrow in there, and then you're going to flush that line, position your patient, and as always, you're going to document that at the end of the procedure. So let's say now it's been 24 hours and it's time to remove the EZ-IO line. You have, say, another good access, or the emergency has ended. You're going to remove that stabilization device, and then you can see here you are going to hook up an empty 10 ml syringe to the hub, and then you want to pull straight back and it will come out. You do have to, however, apply pretty firm pressure, and the main thing here is that you do not want to rock or vibrate that needle back and forth. The photo on the left side of the screen is again directly from the Arrow EZ-IO website, and these are the advice that they give. I've been a nurse for 10 years now, and I can verify that those needles are difficult to grab onto, so you really do want to have that empty syringe handy. Lastly, once you remove the site, you want to apply some sort of occlusive dressing and a tegaderm. You want to monitor that site for infection. For the Arrow EZ-IO drill itself, you want to clean it with some sort of hospital-approved disinfectant. You want to air it dry, and then you want to store it away in the assigned location. Usually these are stored near your crash cart. In summary, today we went over our indications and the contraindications for an Arrow EZ-IO intraosseous access. We went over the supplies that you would need. We went over the appropriate steps for placement, the appropriate steps for checking for patency. We went over what medications you should not infuse, and also that all other medications in blood is safe to give. You can also collect labs with your IO access, and they should not be in, if possible, for more than 24 hours. Once you can safely remove the line, you want to care for the drill, you want to care for the wound site itself, and monitor for sites of infection. Here you see both references that I used to make this presentation. And lastly, I'll just share that this presentation is meant to be accompanied with a hands-on skill station at a later time. So all of you learners who just went through this presentation, now you can feel prepared to move on to the next step, and that is getting with me at a later time during one of our skill stations to practice the hands-on piece of this safely in a controlled environment so that you can feel empowered to make a positive impact at any of the military treatments facilities that the Navy sends you to. Thank you for your time, and please reach out to me if you have any questions, comments, or concerns.